because we have Grant Sara in the room, and I presume, Grant, you're going to do the next two, is that correct?
Yes, apologies. Yes.
Right. That's okay.
Yeah, I know.
So the two presentations that I'll hand over to Grant to give are one on do consumers of mental health services recall receiving information about physical health, and mental health consumers' access to planned and emergency surgery in New South Wales. And I'm sure most of you know that Grant is Director of the Inform branch of the New South Wales Ministry of Health, and both of these projects have been undertaken by members of that team. Over to you.
Thank you. And yes, so sorry, yes, I'm not as billed. It's just me twice. So if anyone does need to make a break for the exit quickly, now's the chance. So look, yeah, this wasn't by design. This conference was planned a long time ago, and we had a number of students and people who were with us at the time who submitted abstracts, and some of them are kind of mid-career researchers now, but it's been so long ago. And unfortunately, Sara, who's our manages our consumer experience measurement work, is down with COVID and couldn't attend. So I'm filling in for her. She would be much more entertaining than me. So we know that information is a really important part of action. Providing people information about their health, it's not enough. Just information alone doesn't lead to change, but it's an important foundation. And we also know that services really need to be providing information, and they also need to keep an eye on how well they're doing that. In fact, I was thinking about it with some of the broad themes in the plenaries yesterday. If we look at the equally well-focused areas or the Lived Experience Australia framework, there's an information dimension to those. We've got to measure progress, we've got to promote awareness, we've got to ask, we've got to advise. And so, information's critical. So what we wanted to do in this work is to look at are our services in New South Wales providing information to consumers in a way that they recall? And the way we're measuring that is through the Your Experience of Service, or YES questionnaire. And it's a pleasure to present this with Perry O'Shea in the room, who is really critical. And in fact, I think the name YES was even Perry's idea many moons ago. So, yeah. So, but... so YES is the national consumer experience measure. In New South Wales, every state and territory has done it slightly differently. In New South Wales, we have it available as a continuous survey rather than a kind of once a year survey. So it's available, in kind of hot boards in services and also electronically. And so it's actually, we get quite good returns. So we have last year around 24,000 questionnaires despite COVID. We collect it in two ways, through paper and electronically. And if anyone did want to point their smartphone at the QR code, you can, have a play with it. Or there's a link there, www.yourexperience.health.nsw.gov.au, and we've got a sort of dummy service code U000 where you can actually just go into the data and see what that looks like. But essentially, that flows into a database, and we provide data back to teams with a range of frequencies and also both in paper and as an electronic app, and also in an annual public report. And broadly, the YES survey results are broadly representative of New South Wales consumers. So just to give it some context before we look at the results. Because of the way we offer it as a continuous survey, it's hard to do a traditional survey return rate. We know we get more returns from hospital consumers. We know there are some voices underrepresented, particularly younger consumers in the community, older consumers in inpatient settings, people receiving involuntary care, and particularly people with brief care. So what you're seeing there is the yellow circles are the proportion of people in each group in the YES returns. The blue circles are the proportion in our overall New South Wales clients. And you can see where there's a big difference in size. They're unequal. So when we rolled out YES, there's a bit of flexibility with the YES tool, and states or services are allowed to add or subtract some questions. And so in consultation with colleagues, particularly at South Eastern Sydney, we added in some questions based on the healthy, active lives or heal declaration, and just asked, in the last 3 months, has the service advised you about the following? So it's those 6 areas there. And people answer no, yes, not sure, or not applicable. And the not applicable is only for the ones with the asterisk, so smoking and medication side effects. They weren't originally there, but we found that people would often go, well, I don't smoke, so what should I do? You know, but we haven't allowed a not applicable for diet, alcohol and drugs, sexual health or exercise, because that's applicable to everyone. Again, some people were not on medication, and so said, well, you know, what should I answer? And this is what we find, that for most, so this is the data for 2021, but it really hasn't changed dramatically at a state level. So for most of the questions, between half and 2/3 of consumers recall being given some information. So what you're seeing there is the lighter blue bar on top is the hospital consumers, and the bottom darker blue bar is the community. And you can see that the questions that people recall being spoken about the most are exercise and diet, medication side effects, and least is sexual health. There are some differences with the hospital and community. So the community consumers recall slightly more about side effects, for example, and exercise. So I mean those results are in some ways comforting and in some ways troubling. So for example, the idea that we know what a role medication plays in inpatient care and community care, but if only 60% of people in hospital are recalling any information about medication side effects, that still suggests quite a big gap. I should say on that, in doing this, we count not sure as no, because we think if someone says, I'm not sure whether I was told that, then it probably isn't having a big impact on them, like it's probably not available there for them to use or act on. So it's important to say, of course, this doesn't mean the information wasn't given. We're assuming there's an interaction with the service, some information given verbally or in writing, and then at some time later we're coming along with a survey and saying, so it might be that the information was given, but it's not recalled. Might have been given at the wrong time. It might have been given in a format that didn't make sense to people. We still think it's legitimate though, because if you can't remember it, it's not going to help you. And so sometimes when services will often say, well, hang on a minute, we make sure we give it, but I think that's the argument. Look, if people who use your service can't remember being told this, then that's your problem to fix, not their problem. You need to give it in a way that makes sense. And if we think about different groups, in a way that makes sense to different groups, to young people, to older people, and so on. We do see a lot of variation across our local health districts. And so here, each of these bars is one local health district, and we've just anonymised them. But you can see there's quite a spread, between them in both. And there are some LHDs that do well across the board. So you can see the green LHD there, LHD 16. There are some that have low rates across the board. So looking at, LHD 9 down there, or LHD 18. And there are some that are kind of up in one and down in another. And we do see that also in the broader YES experience as well. There are some places that have really put a lot of work in, say, for example, in a couple of inpatient units, but things are really lagging in some community teams or vice versa. So it really is important to be able to provide the data. And we know that one thing that drives change in services is competition and, comparative data and not wanting to appear, an outlier. So we also looked at, because those were averages across, broadly across hospital and community, but there are some important differences. So we found that younger people were less likely to recall information about all physical health questions. And that might be, as anyone who's a parent who's had teenagers, that may just be that younger people don't recall anything, but definitely, I think more seriously, it probably speaks to, are we providing the information in a way that's useful and accessible? Yes.
You could also argue that under 18-year-olds would probably remember it slightly more vividly because they actually don't get talking about these kinds of topics by health professionals.
Yeah, that's a great point, actually. You're right. So if they were told, they'd be more likely to recall it. Yeah, okay. I think that's an excellent point. when we look at older people, we found that older people were slightly more likely to recall being given information about diet and exercise, but less likely to recall information about smoking, drugs and alcohol, and sexual health. And I think there was, in this room yesterday, there was a really interesting work on the older person's mental health prompt that's been done, and really that discussion about partly people, not assuming that they shouldn't ask these things, not assuming just because someone's over 65 that I shouldn't ask them a sexual health question or a drug and alcohol question. And some of this is about clinicians and services dealing with their own discomfort or their own assumptions. Oh, yes.
It's interesting the language, with shape and driving change and thinking about that. Just drugs and alcohol as opposed to alcohol and other drugs. It's really shapes a very different way I think to see that.
True, yes. Again, there's a lot of variation. This is looking just at one particular question, which is the drug and alcohol question. And you can see really huge variation. We've got 2 LHDs there where 100% of people in child and adolescent services said, yep, I was told about this. And others where it's really down at less than 1 in 5. So partly our goal with trying to use some of this information is to give it to LHDs in a way that drives that discussion. Clearly it's possible to provide information in a way that's remembered. Some services are doing it and doing it well. How do we get other services to learn from them? There were gender differences. We've scratched our head about this. We found that men remembered more often than women, which is usually the opposite of what you expect, really, for anything related to health or cognition. We have checked, and isn't a data error.
It might be that they would ask more.
Yeah, it might be. It might be that issue that you've just mentioned as well about that's people don't normally ask me. And look, we have several. We have quite a number of respondents where people identify as a gender other than male or female. In general, that group of consumers reports a fairly negative experience, I have to say, across the board, and certainly also here in this area report less positive, less recall of information. One of the important, useful things with Yes, we actually get good and proportional response rates from Aboriginal consumers. And overall, there are complex patterns. It's not uniformly better or worse for Aboriginal consumers who respond to Yes. What this is showing is you've got hospital consumers on the left, community responses on the right. Aboriginal consumers are shown as the blue dot, other consumers as the grey dot. And so if the blue dot's to the right, that means people are recalling more information. And you can see particularly at the top there, I think there's a box around that. In fact, particularly in hospital settings, but in both settings, on the whole, Aboriginal consumers are reporting that they are being provided with information they recall more often. That might reflect greater awareness in services about some of those risks and comorbidities. We don't know, but that's important to know that pattern. Look, the other thing that Sarah's been looking at in this is what other things relate to these HEAL questions. And this is, what you're seeing here is we've taken, so if we just look at the hospital group, for example, on the left, what we've done is split the responses based on people's answer to a different question, which was I involved in a care plan that considered all of my needs? So it's a kind of overall question about care planning. What Sarah found that was one of the questions that most strongly predicted whether people recall this information about physical health. Now, it might be that they're both reflecting the same kind of processes in the service, but it might also be that if you've got a good care planning process and you're including physical health information as part of that, that really, is more likely to be part of an effective approach, rather than, for example, someone, at the discharger says, here's a leaflet on something, or the registrar at the end of the session says, by the way, have I told you about these medication side effects? So having it built in and integrated seemed to be strongly correlated with greater recall. The other thing is we're not experts on analysing text and qualitative information. We do review it, and the LHDs certainly review it and use it. And it is physical issues do come up often in the free text questions within Yes. So we ask a question that says, "What would have made your experience better?" And there's people often raise issues about alcohol, drugs, medication side effects, physical health. Sometimes not with suggestions that there's the issue about we'd like a smoking area, but it often comes up. Conversely, we also ask, what were the best things about the care you received? And issues about physical health do come up there. So when it is offered, when services do it well, it's valued. And so people talk about having support of a dietitian or having activities, having particular workshops, being heard on these questions, and again about people just being accepted. So I think like the people weren't weirded out when discussing sexual health. So, as Perry will know, a critical part of this is not just like what we want to see is this is used for action and change. And services definitely have reported using some of this data. I mean, I wish I could tell you that every service has reported changing on this data. I mean, as always, there's good practice examples and there's others that are laggards. But a couple of services, so one service was looking at those questions about medication side effects and implemented some face-to-face discussions and groups with pharmacists. We do give the services this electronic app where they can drill in and look at individual questions for different age groups or genders or subgroups of consumers and for individual services. And so one particular service was looking, this is data from an older person's mental health unit, and the tiny unreadable numbers across the bottom, my apologies, are years. So it's looking at their change year on year in this question of information about exercise. And so this particular unit, as part of looking at its broader results, implemented some exercise physiology, saw some broader changes, and it was reflected in people's answers to those questions. So it's possible to use some of this data to help support change where you've got a motivated team. So just to conclude, look, we think including information on physical health has been a useful part of addition to our Yes surveying. We're probably going through a process of thinking, okay, it might be time to kind of think about updating the Yes questionnaire. Is there anything we need to do to add? There are some demographic changes we need to make, for example. We're pretty committed to keeping some questions on physical health. We're happy to modify the wording, but it's such an important issue. We're really keen to keep it going. They do seem to shine a light on the issues we know that are there. They do show variation between services. They do provide information that could hopefully be a bit of a nudge or a bit of a support for services that are trying. So we know services often give information, but they often give it badly. If we want to support consumer health choices, we need to get the right information at the right time and in the right way. And just to really acknowledge Sara, and I wasn't sure you were going to be in the room today, Perry, but yeah, just to acknowledge the work with Yes has been very much done in partnership, with Being New South Wales, and then there's a companion work with Carers New South Wales, mental health carers, about the carer work. And Sara, who's our manager, who's fabulous. So.
Before you go on to the next one, Grant,
yes.
Give you a minute's break. Hope nobody minds if we go over by 5 minutes or so, maybe 10, depending on questions. Are there any questions? Just one or two? Okay, two only.
I was just thinking, when you were speaking about older women not retaining the knowledge as much as men, I was wondering, could that be related to the fact that being older and taking older style medications that could have affected their brain, or if they've been exposed to ECT, that affects memory as well?
Yep. Yeah, look, I think they're good thoughts. And I do think, to me, that emphasises that services need to be thinking about having a whole range of information available that kind of matches a person, and where they're at. Everyone struggles to remember, what they've been told. If you've had some of those experiences, that's going to, you definitely need supports, prompts. Here's what's some suitable written information you can take home, or a site you could link to, or, yeah, absolutely.
I think when we use the data, we don't know whether or not it's that they went fast, or they won't ask in a way that was accessible, because often people say they get asked when you're like, in a crisis situation. And then halfway through the assessment, we don't really worry about that. We're rising responsibility and these job, or whether they're doing the call. So, as Grant said,
at the end of the day, if they recall, we are asked, and if they weren't asked, in the right way.
Absolutely.
The right way. And it might be like
Yes,
that.
look, I just wanted to make an observation. At the very beginning, you talked about advice, and that same word came up in Casey's presentation. In the mental well-being environment, we don't use that word. We use negotiation or collaboration or conversation. We actually teach people to not use the word advice because it's inappropriate. And I wonder if maybe the mental health sector's got something to teach the physical health sector in that regard.
Yeah, yep. No, look, I think you're right. It needs to be about supporting individuals' choice and agency, not about finger waving. Yep.
One more question, and please be tolerant that we'll run over time.
Just with little ones, my gerontology had on that, but I was just thinking about age and how old, so you saying old is, and also interesting cultural thing about for old when you're in the cohort. Shame, what is shame comes in certain
Yep.
questions, and that would be possibly masculine.
Yes. Yeah. Look, absolutely. Very good points. Yep.
And I have one final question,
Yes.
which reflects the view of me, I suppose. You've done all that to inform LHDs.
Yes.
What's the response? Are you measuring change?
Well, I mean, yes, we are measuring change. I mean, those examples of individual services making change are there. And like we've definitely trying to, if we look at a state level, there hasn't been dramatic change yet. I do think we need to do a bit more pushing. I mean, it's been hard to push this last year or two. We've relieved that it hasn't gone backwards in COVID, these scores at least. But yeah, I think it's a useful prompt to say yes. Well, yes,
It should be a fabulous policy improvement cycle.
absolutely. Yeah.
On to your next one.
Okay. So we're going from rich narrative, data directly from consumers to big data on surgical procedures now. So it's a bit of a shift of gears. My apologies. And I'm presenting this on behalf of Julia Hamer, who's a final year medical student who did this as part of her research project that they're required to do with us, and did a really great job. So, yes, look, if I could just acknowledge the Yagambe and Kombumerri people on whose lands we meet, and also that in this we're looking at data from people who've used New South Wales hospitals, New South Wales community mental health services, and we do that with gratitude and respect, and with the goal of trying to improve care for people using those services. So we thought that looking at surgical care might be an important thing to do because surgical care is such a big and important part of the health system. We couldn't find much information about it, and it's important to know, well, are mental health service users getting equal access and equal outcomes for surgical care? And perhaps naively, in starting down this road, we had a kind of simple mental model, which is there's a need and there's a supply. People have a condition that needs surgery, and we can look at whether they get surgery. But quickly we realised that this is actually slightly more complicated than that as to what we expect to see. Because if we think about, well, what makes someone need surgery, and what does it even mean to say someone needs surgery? We know there's a whole lot of drivers of potential needs. So there are things that lead to people having conditions. People have got risk factors and social determinants and exposures that mean they've got more likely to have conditions that need surgery. But also, there might be differences in the levels of people's access to prevention and early care. So in some ways, surgery is a marker of late care. If you can intervene early with an illness, you might avoid surgery altogether. So people living with mental ill health might experience more risk factors and less early care, and therefore have more need, was our kind of hypothesis, I guess. But we also know that even in a relatively accessible health system like Australia, there's huge barriers to accessing surgery when you need it. And barriers or enablers based on cost and insurance status, based on where you live, based on the choice that your clinician makes, your GP's referral networks, the surgeon's preferences, and your own preferences. And we also thought, well, it's quite likely that people living with mental health conditions might experience more barriers and therefore have reduced access. So we found it hard to kind of predict. Do we think this is going to, how are these things going to play out? You know, what's the collision between these things going to be like? Are we going to see more surgery or less surgery? We looked around and there's very, very little evidence. We were able to find a couple of studies from the US that mainly looked at planned orthopaedic surgery and back surgery, things like that, and found low rates in people who were in contact with mental health services. But the US is a very different health system with very different barriers. Thank goodness we're not accessing care there. We also thought that the other thing that happens, if someone's facing barriers to planned surgery, you're on a waiting list, you're waiting years and years. Sometimes what happens is you end up having that surgery as an emergency instead because things get worse. And so that it's important for us not just to look at surgery overall, but whether you're getting planned or emergency surgery. Because we do know that if yes. Yeah, no, look, that's a good point. And in fact, because I think that underlines the point too that, emergency, that has important implications for outcomes because if someone's getting emergency surgery, well, they've had suffering and disability potentially, while they were waiting, but the outcomes of emergency surgery, and in fact what you're saying is even the actual process might be quite different, and often it's associated with worse outcomes if the procedure's done as an emergency. So we wanted to ask, overall, what's the rate of surgery for people who use mental health services in New South Wales, and does it differ for planned and emergency surgery? So this is part of our Mental Health Living Longer data linkage, which is this 6-monthly linkage that we're doing to try and support efforts to improve premature mortality in mental health services. So we link a range of data sets. In this, we're primarily looking at hospital and community mental health data. And the outcome measure we're looking at here is surgical procedure rate per 1,000 people in New South Wales public or private hospitals. We've taken a 1-year study period. We used 2018-19 because that was the most recent private hospital data we had. And then we've defined people's mental health care status for that year and the preceding 2 years. And by mental health care, what we mean is anyone who's had an admission to a public or private mental health unit or with a primary mental health diagnosis, or any contact with our state community mental health services. So we don't, unfortunately, have data on private specialists or NGO or Headspace, those kind of services. We wish we did, but we don't currently. And then we've looked at overall rates and incident rate ratios, and then there's also done statistical analysis within the group. What we've tried to do is just focus it on surgery, and certainly part of the learning curve for us in this data was that procedure codes, there are so many procedure codes, and a lot of them are nothing to do with surgery. We also tried to exclude hospital admissions that were for two mental health units, hospital admissions for ECT, hospital admissions for rehabilitation, basically focused on acute general hospital admissions. And also we've taken out of this data, because we think it's important but different, obstetrics and childbirth. So here's what we found. In the year we looked at, there was about 2.5 million procedures that were in scope. And we had about 250,000 people who'd had recent contact with mental health services. The rate of surgical procedures in people who use mental health services, this is all procedures altogether, planned and emergency, was higher. So it was about 40% higher, an odds ratio of an incident rate ratio of 1.4 there, which means if it was 1, it would be the same. It's 1.4, means it's 40% higher. But we know that people who use mental health services in this data are younger than the rest of the New South Wales population and also more likely to live in more disadvantaged areas. So does that explain any of this difference? If we adjusted for that through standardisation, the answer is no, it doesn't. If the differences were due to those things, then you would expect that adjusting for them would reduce the risk closer to 1. In fact, it doesn't. It moves it slightly in the opposite direction. I'm not sure I can entirely explain that. But essentially, simple adjustments like this don't change that increased risk. when we split it by planned and emergency, there's a really striking finding, which is that, so what you're seeing on the left is that total figure with that 1.4. Here the bottom line is 1. So if the rates were the same in mental health service users as in the rest of the population, it would be sitting there at the bottom at 1. But what we see is that particularly what's driving this increase is very much an increase in emergency surgery with 3-fold increases. And the statistical adjustment doesn't really make any material difference. So overall, about 80% of procedures here were what we defined as planned, and that's why the overall rate's closer to the planned rate. I should mention one of the limitations in our study at this point is how we've defined planned versus emergency. So in classically, the way to do that is to look at surgical waiting list data, and if someone's been on a waiting list, then that's a planned surgery. We don't have access to that data, so we've used the there's a field within hospital data as to whether it was a planned admission or an emergency admission. So we've used that. It is possible that someone could have a planned admission but still have emergency surgery. Someone might have come into hospital for something planned and then fall over and break their hip and need a replacement. But for this exercise, we've assumed that's, a small factor. Surgical procedures are organised in kind of big chapters that are called blocks, and then in the individual procedures, and there's tens of thousands of them. If we just look at that kind of chapter level, like the block, the types of procedures that were increased the most were neurological procedures mostly, and when we had a look at those, that was a lot to do with pain and chronic pain procedures. Most things were increased. It wasn't that just a few things were increased, pretty much everything was increased. The ones that were increased slightly less were gynecological and prostate procedures, plastic surgery, oral surgery, and the only block that was reduced was eye surgery, where mental health service users had slightly less rate of planned eye surgery than, and that would include cataracts, than other people in New South Wales. If we looked at emergency surgery, again, nearly everything was increased, and for some of these the numbers were small, but the two that really stood out were thyroid and parathyroid. Not something we thought about beforehand, but it does make sense. There's a strong connection between thyroid disease and mental health conditions, and so some of these might be, for example, where the thyroid condition is also contributing to someone's mental health condition, or it might be that some of these are effects of lithium or treatments, but certainly nearly 20 times more likely. And the other one that's really striking and troubling and was actually much larger numbers is emergency dental surgery. And we've seen that in other data as well, where it's admission for dental infection. And, I think we all understand, but it's just such a reminder of the terrible state of dental healthcare and its impacts. How am I doing, Chair? Okay, great, I'll go up. So, look, in looking at this, we were wondering, well, could some of this, is this due to the fact that for the same condition people are getting in different care, or is it just because there are different conditions? So some procedures are almost always emergency, fixing fractures, is almost always urgent. Fixing varicose veins is never, almost always planned. And is it just that people are therefore having a different mix of procedures within these blocks? So to look at that, what we've done is said, well, one way to do that is let's look at all of the blocks where there's a reasonable mix of planned and emergency within the one procedure. If we get rid of all of those ones where more than 95% are planned or more than 95% are emergency, and it's possible to have either, we've done that. And we've also got rid of some of the very tiny blocks. And that excludes about half of the overall procedures in the state. And then once we've got those procedures, then we've done a statistical analysis to say, amongst everyone who had the surgery, are people with mental health conditions more or less likely to have it as an emergency? So what we found overall is that the same imbalance is there, really. That overall, you're more likely to have emergency surgery if you are at the extremes of age, so under 40 or over 80, if you're living in a disadvantaged area, if you're born outside of Australia. After you control for those things, in fact, mental health service contact was the strongest single predictor of emergency versus planned surgery, and with an odds ratio of 2.5. And adjusting for all of the other covariates really didn't change that outcome. We still were kind of curious though as to, well, is it about the same procedure? Because even within those blocks, like those chapters have a lot of procedures, and it's possible that we're still seeing things that aren't just directly about care. So we had a look at this small number, like zooming right in. So AHW defines this group of access-sensitive procedures, which are specific things where it's easy to kind of imagine what the care is. So there's two, and of the ones that kind of made the cut for us in terms of getting rid of the planned versus non-planned mix, there's two cardiac ones, artery grafts and angioplasties. There's two kind of abdominal surgery ones, cholecystectomy, so gallbladder repair and hernia repair, and two orthopaedic ones. So what you see here is the overall rate per 100,000, and the blue bar is mental health service users, the grey bar is the rest of the New South Wales population. So you can see the rate's higher in overall for those procedures. So even when you look at individual procedures, we're still seeing that same pattern of a higher rate of surgery. And then what you're seeing here is within each, you've got the blue section is mental health service users, and it's showing you within each group what proportion of the procedures were emergencies. And you can see across the board much higher rates. So for example, if we look at hip replacement, 42% in the mental health service users were as an emergency procedure as opposed to 18%. Coronary angioplasty, much the same pattern for most of them. And when we looked at it statistically, after adjusting for all the other factors, emergency procedures were 1.8 times more common for these specific procedures. So to conclude, Chair, with apologies, this is what we found, that people living with mental health conditions in New South Wales, or people using mental health services, I should say, because that's really our measure, had an increased need for, likely to have an increased need for surgical care and a reduced access to care. And the way it panned out, we think, here is that overall surgical rates were increased, but particularly for emergency surgery. So those US studies found lower rates. It might be that, in a health system like Australia, the greatly increased need overcomes the increased barriers, and we see greater rates. We definitely need to do more work here. Doing this work was much more complex than we'd anticipated, and the important thing, I think, is really not the rate. There's issues there from a health economics point of view, but the issue is really the outcomes. And if you're not getting the surgery you need when you need it, thinking about some of those emergency procedures were cardiac. If you're not getting that surgery, some people are dying waiting for surgery, or some people are seriously disabled waiting for their hip replacement. And then that issue that you raised, that even then when you get the emergency surgery, the outcomes may be worse. So I think understanding these and leading to that is really worth pursuing. I just want to acknowledge Julia, who did a great job as a student working on this. Also wanted to acknowledge we've had really great interest and support from Michael Solomon and Kate McBride at Royal Prince Alfred Hospital Department of Surgery. Kate's done some really interesting work as part of her PhD looking at the experience of surgical care for people living with mental health conditions, and also attitudes and views of surgeons about people living with mental health conditions. So they've been really interested and supportive of this work. Thank you.
And very well done. And I'm going to lead off with a comment, if I may, as someone who's been close to some of this stuff for a long time. It shows two things from my perspective. One is that the pathway to emergency surgery in particular is likely to be a mix of things, and most particularly poor access to primary health care and the management of chronic and complex conditions.
Yes.
And in terms of the reference to the American circumstance, we do have in Australia access to emergency care as a public right.
Yes.
You don't in the United States.
Yep.
So the data is not comparable.
Yep. Absolutely.
Any questions?
Yes.
I'm really interested in. Sorry, I've got a very small voice and a toothache at the moment.
Oh no. Do you need emergency dental surgery?
I would be very interested in a kind of qualitative analysis of, people who participate in emergency implant surgery, mental health and non-mental health conditions, because I wouldn't be surprised if, some of the contributing factors to higher rates of emergency are, as you said, reduced access to primary care, but also reduced trust within the community services to manage those effectively. And I'm also interested, so I really appreciate that this data is looking at, well, what are, surgery-related chronic conditions and those kinds of really major disabling conditions. But I would like to hear, I guess, what the experience for mental health users who are receiving emergency or planned surgery in relation to self-harm or other kind of behavioural issues, how that affects their access to the system, and also whether or not they would consider accessing the system for other issues.
Yeah, that's a very good point. Look, I mean, I think, like you, I'd love to see that data. I mean, I think part of the role of this kind of big, observational data is to help prompt. I mean, there's so many questions it can't answer, but and this is really some of the first presentation of this work. We'd love to kind of engage with some of our services to get them to kind of look at some of those kind of issues. And certainly I think, I don't know whether Kate McBride's work particularly looked at planned versus emergency, but she certainly did some of that kind of qualitative experience. But those issues of stigma, diagnostic overshadowing, the surgeon who goes, I'm not going to do this because, those are very real yes, absolutely.
But it does make the point, and I think if I could paraphrase your question about what questions this raises, it does make the point that big data, which is the expression I've used a lot, is so rich in information about what's not working and who's being affected by it, that we absolutely need to see this as core business for health agencies and the like, because it shines a light on the dark spaces we can't see.
Yeah.
I work for an organisation that does men's mental health support for men.
Yep.
The Marcus Mission program through Wesley Mission.
Right.
And I can see some real implications for their work where their conversations with men about men's health.
Yes.
Particularly that stuff about hernias.
Yeah.
There's a lot of men obviously who are a lot of men and women who are obviously very uncomfortable, and that can't be helping with their state of mind as well. And some conversations at the right time are really warranted in the community rather than in the hospital.
Absolutely, way upstream. I agree.
And now, because
and there's two
very
questions.
short, is there?
There's
Okay.
It'd be very interesting because the data we're looking at now, that's called pre-COVID. I wonder if you're able to do another research, because it would be very interesting to look at the surgery rates now.
Yeah, look, absolutely. I think that the ability of COVID to have kind of opened up inequalities, in access, absolutely, yes.
They also cancel a lot of elective surgery.
Yeah.
That's right. There would be incomparable because of the cancellations of elective surgeries. Can I thank our presenters and thank you for your patience and for managing to make it an interactive
Thank you.
session. Thank you all so much, and thank you, Grant, for a double presentation.
Yes.
Go to lunch.